Welcome to the Disc Golf Doctor. Today's topic is tendonitis. It's something that a lot of people deal with, and many people misunderstand what's going on and therefore misunderstand how to treat it. It's a discussion I've seen very often in forums lately having to do with disc golf. I see a lot of suggestions that are incorrect or at least misguided. So I wanted to go over this topic so people had an understanding of generally how to approach it. Specifically, we're going to talk about the elbow. Obviously, you can see these kind of injuries in the Achilles, the patella, really all throughout the body. But the ones that are most specific to disc golf and most common are at the elbow. Certainly, you could argue that certain shoulder issues could be this type of injury as well, but it's usually more complicated than that and not as definitive, whereas the elbow is fairly straightforward in a lot of cases. To treat or prevent any injury, you need to understand the physiology or pathophysiology involved. Otherwise, any treatment or prevention methods will be ineffective because they're not going to get at the heart of the issue. That's the problem with tendonitis. People misunderstand the basic process going on, and therefore the treatment suggestions are often incorrect. To understand what's going on, we have to look at terms first of all. People use the word tendonitis all the time. I used tendonitis a moment ago. When you consider itis means inflammation, it would infer that there's inflammation of the tendon, that it's an inflammatory condition. But when you do a biopsy of a tendon going through this issue, there's no inflammatory cells present. It's not an inflammatory condition. So people who are recommending anti-inflammatory treatments are not getting to the main issue at hand. What is actually going on is there's micro tearing and degenerative changes in the tendon that take place. You can see that if you look at it with diagnostic imaging such as ultrasound. We now tend to use the terms tendinopathy or tendinosis because it implies the structural changes in the tendon that we see. So with regards to the elbow, there's two main tendinopathies that we see. There's the lateral and the medial, typically called tennis elbow or golfer's elbow. In the normal population, you see about 80 to 91% of those with tendon issues in the elbow happen on the lateral side or tennis elbow. My guess is there's a disproportionate number of people who play disc golf who have it on the medial side, particularly those who throw forehand. That's what I've been seeing on a lot of the forums of people not being able to throw forehand for a period of time because they're primary forehand throwers and they started to develop elbow issues. So we can talk about some of the mechanics going on there and how to therefore treat it. So anatomy-wise, if we're considering the medial tendinopathy, or what we would sometimes even term epicondylopathy, start with a common tendon on the medial side of the elbow. A lot of the flexor tendons and even the pronator tendons all originate from the same single tendon essentially. It all happens right here in the medial part of the elbow. The two muscles that are often involved with medial tendinopathy are flexor carpi radialis and pronator teres. Those two, at least that portion of the tendon tends to be one of the main issues. There's lots of studies that look into both lateral and medial, how to diagnose it. There's no fantastic tests, but a lot of times, based on the subjective information someone provides, it can be pretty clear what's going on. Most of the time, they'll be fairly tender to the touch in that area. Not that you ever want to use tenderness as a main diagnostic tool, but if it matches with their symptoms, oftentimes they'll have pain when they're engaging those muscles. So if they're trying to flex their wrist against resistance, or even if potentially even pronating, rotating the forearm in against resistance, it will most likely be painful. It's not only important to understand the physiology going on, but understanding the mechanics is important. There's a bit of a debate between whether this is caused by repetitive contractions over time or if it's due to eccentric loading. Eccentric loading is when your muscle is engaged, but it's lengthening. Repetitive motions are pretty straightforward. They're things like if I'm typing, if I'm clicking on a mouse, if I'm on my phone, all these little things we do with our fingers and forearm muscles repetitively can put a strain on the tendon. Alternatively, if we put our arms in very extreme positions where those structures are being strained while trying to contract, you can cause damage to the tendon, such as when I go to throw a pitch. You see it in pitchers as they're getting back in this layback position, they're straining some of the structures here in the elbow while trying to engage at the same time. And that's one of the reasons why not only see tendinopathies in those pitchers, but you also end up with things like Tommy John surgery because they're not only straining the tendon, but even the ligaments controlling the joint. So the reason you see this so often in disc golf is that people who primarily throw forehands are doing a very similar motion with their throw as do pitchers. Instead of being in this layback position, the elbow is a little bit lower and throwing still with that lag, getting that elbow forward to get some of the power. And that puts a lot of strain on the elbow. It's not a big deal oftentimes if you're throwing only some forehands throughout your round. But if that's all you're doing, you're putting a big strain on the elbow. One of the biggest things I would suggest for people in those situations would be to start throwing backhand more, whether it's learning it or you just using it more frequently. That's going to be one of the biggest things is maybe not throwing forehand quite as much. We could certainly get into hours of debate on form of whether your elbow should be down by your side or a little bit higher, or really should you be leading with the elbow, but that's not necessarily our discussion. So outside of changing up form, I think the more important thing is to potentially consider altering your grip. A lot of treatments that people use and have some success with often involve little changes on where the strain goes on the tendon. So you see those straps around the wrist, the elbow, and I think a lot of times people get some relief because it changes where the load is put. So it maybe not put as much on the pronator teres or the flexicarpi radialis. And we could do the same thing with our forehand grip. There's a couple of main grips that you see. You see either sort of this stacked grip with fingers like this. Oftentimes you'll see a grip like this. There's some alterations of that, but those are kind of two main ones we see. And if you can think about it, the strain put on the tendon is going to be different because of how the muscles are going to be engaged and where I'm putting strain. If I have this stack grip, oftentimes I think honestly people can get a little more lag in this position than if I have my wrist kind of turned a little bit more this way to get these fingers one on top of the other. Then I think you don't get quite as much lag and the angle is going to be slightly different. And I think you're going to engage the muscles slightly different. So I would consider, if just trying an alternate hand position on the disc, that alone may change up where you're putting strain on the tendon. I don't think that relieves you from the need to take a break from throwing as many forehands, or perhaps not as hard with the forehand, but that's one additional thing you could potentially do. The other main treatment for this kind of an issue would be what we call eccentric loading. I know I talked about how excessive eccentric loading can be a cause of the issue, but studies show quite clearly we need a form of loading to cause the tendon to start laying down new healthy tissue to fill in those gaps and repair the tendon. So there is a debate in the research as to whether to do that eccentrically or concentrically, or really kind of a total load on the tendon. But any tissue responds to strain. When you strain your skin, repetitively, say you were to rub up against part of your hand repetitively, you start laying down more skin cells. It becomes a callus. Same thing happens with bone. If you strain an area of bone, you get a bone spur or more formation of bone. Same thing happens with the tendon. If we put a controlled load through the tendon, we signal to what are called the tenocytes to lay down new tendon cells and to fill in those gaps. And studies have looked at that. You work through these programs and then go back and do ultrasound diagnostic testing of the tendon, and you'll see those fibers fill in and the structure be more solid. So the main treatment for this is pretty simple. There's two ways we can do it. One, I think, is the simplest, is with a weight. Go somewhere where you have your forearm supported. You could even just use the arm of a chair or kind of like this at an angle on a table. And what you want to do is have your affected arm start in this extended position. Your good arm or unaffected arm is going to lift up the weight, and then your affected arm is going to lower it down. This is for the medial elbow issues, where it's just doing this eccentric loading. Concentric is when the muscle is shortening. Eccentric is when the muscle is lengthening. So I'm just going to be doing the, like this, eccentric loading. So the affected arm is just lowering the weight. Pretty simple. Studies I've read typically would build up to doing 3 sets of 15 of that at least once a day. Some did develop it up to 2 times a day, but 1 time a day is typically enough. The other means of doing it would be using what's called a TheraBar. It's really exactly the same thing. What you would do is you would have the wrist, the affected arm, in an extended position. You would take your good hand and you would twist the bar so that when you stop twisting, you could let the affected one go into wrist flexion, kind of curling the wrist. You would let go, let the wrist go into extension, create the tension, and slowly go back to the starting position. You'll feel it's really the same thing, of that I'm creating this tension and I'm having to use the muscles in my forearm on the medial side to control that. So I'm working eccentrically. Essentially the same thing, but 2 ways of doing it. So we talked a lot about the medial elbow. Essentially the same thing goes for the lateral elbow. It's just different structures involved, but same thing. There's a common extensor tendon that goes in lateral in the elbow. I'm sure there's plenty of people playing disc golf that deal with that as well. And in the normal population, it's by far more common. I do think that forehand players get the medial elbow, but people could easily be having the lateral elbow issues in general from normal life activities, and then all the gripping they're doing during disc golf just isn't helping, because anytime you're gripping the disc, you're engaging muscles not only medially, but you're using them laterally. And so if those tendons are already irritated, or in the sense of these degenerative changes we're seeing, it's only going to contribute to that and exacerbate that. So same thing goes for that of trying to avoid anything throughout your daily life that's contributing to this issue. Avoid putting your arm in positions that you think are straining it, and then trying to do the same thing but with wrist extension. So instead of starting with my wrist here, dropping down, coming up and lowering it, I'm going to do it this way. If I have a lateral elbow issue, I'm going to start with it in a flex position, raise it up, and lower it down. So same thing, and same thing with the bar here. Instead of starting in extension and curling it and then having to come into flexion, I'm going to do the opposite. I'm going to start in flexion, I'm going to tension it here, and then I'm going to allow it to go into extension. Yep, keep going backwards like that. So you could get one of these flex bars. I don't tend to like it. I know some people argue that it's superior in some ways, but I think it does the same exact thing as the weight does, and you don't have to buy anything unusual. You don't need a lot of weight. I demonstrated with a 3-pound weight. You could just do it with 2 or 3 pounds is typically enough. Essentially what you want to do is you should feel those muscles fairly fatigued by the end of that 3rd set. If not, bump up to a little more weight. That's essentially it. You're just trying to put a controlled load through the tendon. Whatever you can use to fatigue the tendon is good. For those of you who have tried those treatments of avoiding the exacerbating issues and going through a few months of these exercises, and that's really important. The studies tended to do it for about 12 weeks from what I've seen before they really saw the full results. So give it a good amount of time. But if you have and you're still having those issues, then definitely go see a doctor to have them evaluate it further. Make sure there's not some other issue going on, and make sure it's not a extra severe case that isn't getting better on its own. Occasionally you see people having to have surgery for this. It's not very common at all, but it does happen. So have it checked out so you can get back to doing the things that you love. One thing we'll touch upon briefly, but I don't want to go too deeply into it because this video is already long enough. And on top of it, it's going to be very specific to each individual. But you see these elbow issues in athletes like pitchers all the time that don't just originate purely because of the mechanical position we're talking about, but because of lack of either strength or mobility elsewhere. If one of the first things you look at with someone who's particularly an overhead athlete is enough motion in the thoracic spine. Right, you need motion in your thoracic spine to move your shoulder properly. And if you're not moving your shoulder sufficiently, you're going to be compensating by trying to get that motion elsewhere. So for example, if I'm forward here, I can't get my arm very far back. If I'm up here in this position, I can get my arm all the way here. It's a big difference. So if I'm here and I can't get my arm back enough, I'm going to try lagging more with my elbow and putting more strain on the elbow. Same thing goes for disc golf. If I'm not in a great position and if I tend to be a little more rounded here, I'm not going to be able to get as much rotation with my arm, and I'm going to end up putting more strain on my elbow as compared to if I have good thoracic mobility. I've worked on that. I'm going to get more motion in my shoulder, and it's not going to inherently put as much strain on the elbow. It's a little too specific to each person to say you have to do A, B, and C, but certainly it's an issue. And that's why if things aren't going well on your own, like we discussed or will discuss, seeing a doctor can be important, whether it's an orthopedic doctor or probably even first just seeing an orthopedic physical therapist or a sports physical therapist who knows something about these mechanics so they can get into some of it besides just modalities to the elbow and these simple exercises, but oriented a little bit more towards proper strengthening in the shoulder and mobility in the thoracic spine or even mobility in the shoulder. And in general, lots of people will give you their recommendation to, say, ice it and take anti-inflammatories, and that's what's going to make it better, and all these different braces and this and that. I wouldn't really listen to them. Most of those treatments aren't going to be detrimental. So if you ice it and it feels better, there's nothing wrong with that if it modifies your symptoms. But in the end, it's not going to make you better whatsoever. You're going to have the same outcome whether you ice it or whether you don't. If you find one of the braces just puts the strain somewhere slightly different on the elbow, that's fine too. But again, it's not going to get at the heart of the issue, which is restoring the structural integrity of this tendon. It's not as much of an issue with the elbow. You do see tears as a result because of extensive degenerative changes. Oftentimes you more see that with the Achilles because of the amount of load we put through our Achilles if it's degenerated enough. But it certainly can happen in the elbow. So work on these things so you can really improve the issue at hand, not trying to address inflammation because that's not the main issue, but the structural integrity of the tendon. Thanks for joining us today. Have a good one.